Thank you, HemoSonics, for having me. My name is Jürgen Lutz. I'm an anesthetist and intensivist. I work in a 450 beds. You can see the hospital right here. It's basically in the middle of Cologne, and we are an academic teaching hospital. We joined the PBM network in 2018. This is the German PBM network. And right now we are cooperating in two multi-center studies that we're really involved in, and we really dedicate a lot of time to PBM. There are a lot of arguments against transfusion that you already know of, and many points pro PBM, and that really made us start the PBM program in our hospital. There are transfusion-associated complications as increased rate of infarction, although you probably think that oxygen delivery maybe get better with red blood transfusion. The problem of volume overload and the increased tumor recurrence. I also think that TRALI is extremely underreported. We had some severe cases of TRALI in our hospital. TRALI meaning transfusion-related acute lung injury. And there's increased mortality. You all know the studies. This is clearly demonstrated. You also have to think of red blood cell transfusion as a transplantation of a liquid organ with increased infection rate and immune compromise. You all know the shortage of allergenic blood supply, especially in our hospital. We suffered in the COVID-19 pandemic a lot of this shortage. We are a trauma center, and in some days we only had about 10 to 15 units of packed red blood cells to work with. I'm not going too deep into costs, but at least in Germany, the costs of PBM are not reimbursed in the first place. So you have to keep that in mind. This is our pre-operative algorithm that I'm going to walk you through quickly. In emergency cases, we go right to surgery. We can't waste the time to start a really broad workup. If surgery is planned, and the ideal for us is 1 or 2 weeks ahead of surgery, we look at the probability of transfusion. If it's about 10%, we look at the hemoglobin levels, and if anemia is diagnosed, and we diagnose anemia in male and female lower than 13 grams per deciliter, we go to the iron status. And if either transferrin saturation is lower than 20% or ferritin is lower than 100 nanograms per milliliter, we give iron intravenously. If no iron deficiency is apparent, we do the whole workup for the patient and finally, hopefully, treat the anemia adequately and bring them to surgery. I'm going to concentrate on the second column. You're probably very well familiar with the 3 columns. The second column of patient blood management is minimizing blood loss and the intensified use of blood conserving measures. What we do in our hospital is that we exclusively use closed loop systems to withdraw blood, for example, for ABGs, so the waste of blood is minimally. Patrick also mentioned the collection tubes. We use the mentioned tubes. We have the outer size is the same because the analyzing machine only recognizes one size of a tube, although the volume within the tube is reduced by about the half, and the ratio of anticoagulants in the tube is adequate. So if you sum it up for a patient who goes to the OR, who stays in your ICU for several weeks, it can even sum up to liters, as Patrick mentioned, for all the tests that you are doing on the patients. We also extensively used automated autotransfusion. We have a fairly high number of patients who come into the hospital with anemia under emergency circumstances. So we use these systems, especially in orthopedic surgery and in vascular surgery. Now I want to focus on optimizing coagulopathy. You're all familiar with the coagulation pyramid, surgical bleeding control. This is by our colleagues and surgeons. In our hospital, we do packing in emergency cases, vascular suture and ligature, clipping, fibrin glue also is used. We also look very meticulously at the basic conditions like temperature, pH, calcium, and we keep the hemoglobin levels up to a certain level. We also do a history on every patient or on the relatives of the patient if the patient can't answer the question. And the whole tip of the pyramid really can be looked at by the Quantra system. So this was one of the reasons that we didn't want to rely only on lab parameters, but also needed a POCT device at hand in the OR or in the ICU. My former professional background is the University Hospital of Essen and of Hamburg, and they were rather ROTEM-based. So I was already pretty well familiar with the technique itself, which is quite similar, I think, especially the tests that are run are somewhat comparable. This is how it looks like in our hospital. This machine sits at the main operating theater complex. We use it right next to the patients that we're working on. I was asked to talk about the implementation of Quantra in our institution. First of all, we had great help from HemoSonics. I really have to say that they came several times to instruct the medical staff and the nurses to the machine itself. And then they were at our side through the training in the daily use. We had another issue with the integration in our hospital information system that was not really trivial because you need an interface between the Quantra system and the hospital information system. And after that, we did constant training with the cases that we were working on. So we had a real life training, and I'm going to show you some case studies. We also taped a video together with DocCheck, which is an original German medical publishing company, and we put this on our website, and you are more than welcome to download it or have a look at it. We also recorded 2 podcasts that had impressive feedback, and you're also welcome to listen to it. Then we applied for a German funding program. We got 20,000 euros, and we in part used this money to finance Quantra. Not saying that you can go Quantra for that 20,000 euros, but we used part of the money for it and was really well invested, this money. So I'm going to take you through some interesting cases. The first case was a 75-year-old patient for crossover and aorto bifemoral bypass grafting. This was about 1 hour into the OR, into the operation. And what you see is basically normal hemostatic function for the internal pathway, and for the internal pathway, you don't see any hint to heparin, which would be in the system. Clot stiffness is very well into normal. And you see also for the platelet contribution and the fibrinogen contribution, that was within normal range. However, you could see that the hemorrhagic reserve might be a little bit to the lower limit. In this kind of surgery, we use heparin for shortly before the surgeons do the anastomosing to inhibit thrombus generation. And in this case, we thought we administered about 5,000 units of heparin. But what you see in the CT, there are no results. This is just running through, so to say, which gives an indication that there's a lot of heparin in the system, and we probably overdosed unwillingly heparin. You see, if you use the CTH scanner, where heparinase polybrain is added to the system, you are within normal limit. So there was a hint to a high dose of heparin, most probably much more than 5,000 units of heparin. If you look to the external stimulation, clot stiffness was below the limit, and probably this was a problem with the platelets, either low platelet count or malfunction of the platelets. Fibrinogen was within normal limits. So first of all, we treated the overdose of heparin. We had to give 2 times 5,000 units of heparin. I didn't show you the slide in between, but in the end result, this sums up, we gave two times 5,000 units of heparin, and then CT returned to normal. As you can see here, the CTR, which is the index, returned to normal. However, in this case, still the clot stiffness was a little bit lower due to the platelet function, and we took a quick history in this case, and the medical history, if we looked really close to it, a patient was taking antisteroid drugs for pain medication. So this was the reason why we treated this subnormal PCS count with desmopressin, or the malfunction of the platelets with desmopressin. We also gave 1 gram of fibrinogen, and as you see, PCS and also the clot stiffness returned back to normal. The second really interesting case, also a sad case, this was a 69-year-old lady that jumped from a second floor balcony from our hospital in a suicidal attempt. She broke her hips and had multiple lower extremity trauma. And this lady also was admitted to a medical ward. She was on heparin. So this was the reason why we used the Q+ test to rule out heparin effects. And as you see, CTH and CT were prolonged. So the problem, this lady was most probably not heparin, but the thrombin generation potential was reduced. What we do in this case in Germany, we give prothrombin complex, which is called PPSB, reflecting the coagulation factors 2, 7, 9, and 10 to enforce the thrombin generation potential. We also treated the low count of PCS and FCS with fibrinogen and 1 thrombocyte concentrate. And I'll take you to the next slide. As you see, in the internal pathway, values almost returned to normal, not yet completely, but the PPSB that we administered almost returned to CT and CTH to normal level. Also, clot stiffness, let's quickly go back 1 slide. As you see, it came from 3.0 to 7.3. Was much better, and PCS and FCS also augmented. We again treated the patient with 1,000 units of PPSB, 2 grams of fibrinogen, and 1 thrombocyte concentrate. I don't have the last slide at hand, but believe me, the patient stopped bleeding at this moment, and the values completely got back to normal. This is another example of a suprarenal aortic tube grafting. And this slide, all the values are in normal range. This was about 1.5 hours into the operation. And suddenly, quickly after anastomosing, the patient started bleeding. Clot stiffness was somewhat low. And you see that the fibrinogen part and the platelet part contributed to this low CS count. So in this patient, the guidelines would recommend to give platelets and fibrinogen. One of the last cases I'm going to present you, also a very interesting case. The case was extended left hemihepatectomy in a 75-year-old alcoholic patient with a resection for a metastasis from a colon cancer. If you look at the CT is rather on the lower end of the normal. So CT was quicker than normal, showing that there's a great thrombin generation potential moving towards hypercoagulopathy. However, if you look at the CSL, which reflects lysis in this patient, was by 57%. So there's quite a lot of lysis going on in this patient with his liver operation and the history of alcohol maluse. External stimulation was quite normal. So we treated this patient with an antifibrinolytic drug. We used 2 grams of tranexamic acid. And as you see, the fibrinolysis is completely treated. It was by 100% CSL, so means no more lysis whatsoever. And the fibrinogen, we gave 2 grams of fibrinogen, which brought it up to 6.0 hectopascal, which might have been even over treatment, but at this point the patient stopped bleeding and the surgery was successful. The last case I'm going to present to you is a case of a COVID-19 patient who is still in our intensive care unit. And what you see here is massive hypercoagulopathy shown in the much augmented CS, as clot stiffness much higher than normal, and platelets and the fibrinogen count or fibrinogen function leaded to this augmented clot stiffness. If you look at the lab values, plasma fibrinogen concentration was elevated. Normal values in our hospital is 200 to 400, and he was by 630 milligrams. And the D-dimers indicating that there's thrombosis going on or clot formation is going on was also augmented. If we looked at the platelet activation by aggregometry in all 4 activation channels, collagen, ADP, arachidonic acid, thrombin receptor activated peptide, was very well stimulable. This patient, as a matter of fact, had a both-sided massive pulmonary embolism, and in TE you could even see in the main stem massive thrombus. So, conclusion I would want to draw: Quantra is a very useful tool in PBM, especially if you look at the second column. It can be very helpful in the diagnosis of coagulopathy. I showed you the pyramid, and the upper half of the pyramid gives you quite a good insight in what is going on with the coagulation factors and the clinical situation of the patient. QSTAT early detects cases of fibrinolysis. We have no lab value that really indicates you with security that fibrinolysis is going on, to which extent. I think it's very time efficient. It's quite easy to use and to implement. We had a training of about 1 or 2 hours per person in the medical staff, and then they were really trained well. And the question is to keep this training up. And in the poll, in question B, you were asked if education is an issue, and 66% of all the colleagues that they're contributing here said this is an issue, and I totally agree. I think Quantra gives you quite a good understanding of coagulation. You can compare it to the patient that you are treating and can correlate it quite easily to the bleeding situation. So this was my contribution. I thank you very much for your attention. This is our PBM core team in our hospital. Thank you.